Just a brief introduction of myself. I am Panayot Spentais. I am a council member of the Association for the Study of Death in Society, and we have sort of gradually and slowly started holding these webinars just to try and engage colleagues and death scholars from around the world and people who may be interested in practice related to end-of-life policy, health policy, as well as arts and humanities, so that we can start engaging into a wider dialogue as an association. So hello everyone and welcome. We do expect people to arrive as the time goes on, so it is a conversation that is ever evolving, and you might see new people coming into the chat. A couple of housekeeping. It's the basics. I think we're all so used to this right now after a whole year's worth of online working that it's almost self-evident, but very quick note. Do keep your cameras on if you want to, but off as well. It helps with the connectivity, sort of running things through quicker, especially when somebody's sharing their screen. Please do keep your mic off unless you need to come in and share your thoughts or ask a question or share a comment. It will be very useful if you want to use the features of Zoom at the bottom of the screen, just to indicate that you want to come into the mic, and then I'll be giving you the space. Make use of the chat forum. I will keep an eye on that as our speakers are talking, and I will be relaying your questions to the speakers if you don't wish to come into the mic or you don't have a mic to use. And I think that's mostly it. It will run until 6 o'clock. We will have time at the end of the talks to ask questions and have a conversation. But I will allow the speakers to use as much flexibility as they want. If they want this to be more interactive, it is down to them as well. I think this is it from me. And without further ado, I want to open up with our first speaker, Ashton, Dr. Ashton Verdery. Am I pronouncing your last name right, Ashton? Yes. Okay, great. What I have done is I have put the bios of our speakers in the chat so that people can really refer to that easier. But I think just to do a little bit of justice to our guests, Dr. Ashton Verdery, so he is an early professor of sociology, demography, and social data analytics at the Pennsylvania State University. Ashton has focused very much on how demographic change influences connections between people and their health. And he's here to really talk to us about the amazing work he's done to date on bereavement multipliers in relation to COVID, and we're all looking forward to that. So Ashton, I hope I did you justice, but over to you. Are you okay to share your screen as well, or do you need me to? Okay.
Oh, yes, you need to enable that.
Oh, okay, well, let me just do that. You should be able to do it now, I'm hoping.
Excellent. I think it, does that look correct?
Yes, this looks great. Thank you very much.
Thank you. Just going to start a timer just so I keep track. Thank you very much for that very nice introduction. And what I wanted to talk today about is kind of setting the stage, thinking about the COVID-19 mortality crisis in the US and elsewhere as kind of a unique event spurring substantial increases in bereavement. As we all know, the COVID crisis has really been quite substantial. Hundreds of millions of cases globally. In the United States, about 30 million cases. The US is one of the hardest hit countries in terms of mortality, with over 537,000 deaths recorded as of this morning. This has been a crisis that has shifted American lives in a number of ways, including substantial numbers of people unemployed. Last June, there was about 18 million unemployed. It's still about 11 million. About a quarter of people report teleworking over this past year. The vast majority of school children are out of school. And as people who have lived through it know, there's been a number of plans disrupted. We haven't been seeing our families and things like that. Just to contextualize the extent of the mortality shock, this graph shows the typical 5-year kind of rates over the last 5 years of mortality by month in the United States. And then the COVID crisis in red. As you can see, the COVID crisis took off and really was a massive hit early in the spring, and then the second wave over the summer, and the recent wave over this winter has just been levels of mortality every month. This is the numbers of people dying each month, and you can see how much higher it is this year compared to the prior 5 years. What I was interested in is trying to understand the extent to which the COVID-19 crisis is leaving people bereaved. There's a number of reasons to care about this, as I'm sure you all know. A substantial number of people who experience the death of a spouse or a child go on to develop prolonged grief disorder. There's medical indications that people who are bereaved have elevated risks of mortality in the next year following a spousal or child bereavement event. And there's less studied, but a number of other substantial disruptions associated with bereavement, including in people's mental health more generally, their educational trajectories, their employment prospects, their relationships and divorce risks and things like that, as well as their access to social support. Early in the COVID crisis, I think there was this narrative that most of those who were dying were individuals that, for some reason, there was a popular narrative that people were not being missed. And I thought that that sounded, implausible to me. So I wanted to use some demographic modeling techniques to try and understand the number of family members that would be left behind by each COVID-19 death. Just to give a quick overview of COVID-19's kind of age profile, it is starkly age graded. You can look in the United States there in the kind of blue graph, or you can look in China, South Korea, or really any country in the world. And you see substantial numbers of the deaths, much higher risks among the older adult population compared to younger adults. So this kind of age-graded pattern is very amenable to demographic modeling, which is what I was interested in trying to use to understand COVID-19 bereavement ramifications in the general population. There have also been noted in the US substantial race disparities in COVID-19 mortality. On an unadjusted level, it doesn't look like they're that big, but when you take into account that Hispanic and Black Americans tend to be substantially younger than white Americans, you see pretty large race disparities. A classic way of approaching this kind of question of how many people would be bereaved from COVID-19 mortality or might know someone who passed away would be to use this kind of simple network scale-up approach that others have used in the past to estimate the influence of terrorist attacks and things like that on kind of the general population. This is a graph from Jim Moody at Duke University showing earlier in the pandemic the population kind of influence of COVID-19 mortality at the county level in the US. What's the probability that you know someone who died, assuming that people have 20 within county friends, and looking at the variability in death rates across the country. On the one hand, this graph suggests that there is quite a bit of heterogeneity across the United States, but on the other, you see that the vast majority of counties are red, suggesting that 5% or more of the population knows someone who died of COVID-19 at that time. And again, this is about half the death rates that we've seen today, so this number would be substantially different now. What I wanted to use, though, is not this kind of simple network scale-up approach, but a more demographically informed model that takes into account age variation and the kinship structure of the US population. This, I think, has advantages because it helps us to track kind of the bereavement scale of COVID-19 mortality in the absence of real-time data. It also helps us to account for the fact that any snapshot estimate, for instance, the estimate that I just showed from last summer, is going to not account for the entirety of the pandemic. And with the demographic model, I think we can account for COVID-19's bereavement hit across the entirety of the pandemic, which is what I was interested in doing. And the last one is it allowed me to better account for kind of race variation, which I'm not going to talk about extensively today, but it's an interesting component of the COVID-19 pandemic. So I developed a simple measure that is allowing us to track the number of bereaved per each COVID-19 mortality death as the pandemic unfolds. Limitations are that it only applies to white and Black Americans, but I have a number of reasons to suspect that it applies more generally. To do this, I don't want to belabor the methods, but I relied on some prior work that I had done in demographic modeling of US kinship networks, including work that focused on pure computational models as well as surveyed data. And the goal of those projects was to come up with a representative estimate of US kinship networks. And one thing in this paper that we used is demographic modeling, but you can see that the simulation model that is shown there on that graph on the bottom compares quite favorably to the empirical data that we see in surveys. And there's reasons to suspect that most of the gaps are probably more accurate in the simulation data than in the survey data. So what we did is we have this representative estimate of US kinship networks, and then we can model the age pattern of COVID-19 deaths as it changes over the pandemic on the kinship networks and estimate the number of people that would be bereaved for each COVID-19 mortality event. Overall, our estimates suggest that about 9 people will lose a close family member for each COVID-19 mortality death. This is focused on a small subset of our kinship networks, grandparents, parents, siblings, spouses, and children. Obviously, if we were to include friends and others, we would see even a greater multiplier, but we thought that these were some of the most important to focus on as a first pass. We had really interesting estimates that focused on how these deaths are felt across the age patterns. And so the graph on the top there shows the number of people that would be bereaved per death at each age. So you can look at that one point that's circled there, and the interpretation there is that one person in the 50 to 59-year-old age range would be bereaved per COVID-19 mortality event. If you look at the bottom graph there, that disaggregates what kin type is contributing to that top graph. So you can see that for most children, the most common bereavement event is going to be loss of a grandparent, but for most older adults, the loss of a spouse or a sibling is going to be substantially more common. So we can see how there are different kin being affected at each age. Why is this useful? I think it's useful because it helps us to track some of the implications of the pandemic. The current estimate based on the mortality events today would suggest that this pandemic has left about 4.8 million American children, grandchildren, siblings, spouses bereaved. Under current trends, we are thankfully kind of exiting, I think, some of the mass levels of mortality in the pandemic, although it has been a very dark winter. And our estimates suggest that up to about 1 million more people may be bereaved by July, but certainly, hopefully, the bulk of the hit has been behind us. I updated these numbers and I left in the old ones just to show how staggering the decline in mortality has been in terms of what it implies for bereavement. But today, I looked up the numbers, and an estimate from, I believe it was IHME, suggested that there were 1,273 deaths, which implies about 5,100 people losing a grandparent, 2,800 people losing a parent, 2,500 people losing a sibling, 600 losing a spouse, and 250 losing a child just today. This is a substantial hit in the United States. And even though the darkness of the worst days of the winter are behind us, this is still a substantial amount of people experiencing bereavement from COVID-19 mortality right now, and expected to be persisting in the next several months. I did want to make a brief note that our results compare favorably to the demographic, to the network scale-up approaches that I referenced earlier. If you were to use our numbers for the estimated number of living kin that individuals who die of COVID-19 have, you end up with an estimate quite close, which I think helps suggest there's some additional kind of triangulated validity to our model. In addition, I think that this model is very helpful for understanding kind of broader ramifications. If you think back to that chart where I showed the kin type hits by age, you can see in that chart that there was about a 10%, a 0.1 multiplier for each, it's actually 0.078, for each COVID-19 death among children 0 to 18 losing a parent. This would suggest, if we use that and the actual death rates, that currently in the pandemic, about 37,000 to 43,000 children have lost a parent. Most of those children are between the ages of 10 and 18. That is because most of the people who are dying are older. So most of the children 10 to 18, their parents tend to be 45 to 65. So that's where the bulk of this hits, but still a non-trivial number of children under the age of 10. Elementary school age children have lost a parent, our model suggests, owing to COVID-19. If you wanted to contextualize this against typical year kind of experiences, this would be about a 17.5 to 20% increase in the number of children who've lost a parent to COVID-19. So in a typical year, we see about 200,000 losing a parent, and in this year, we're adding an additional 20% or so to that number. We've also begun looking in other countries, trying to understand if these results generalize to other contexts, and using some empirical survey data that was captured at a single point in time. One that's particularly interesting, and is a paper that we have under review right now, is from the Survey of Health, Aging, and Retirement in Europe, which surveys older adults above the age of 50 in 27 European countries and Israel. And these data were collected in June to August of 2020. And they asked individuals if they knew anyone who had died of COVID-19, and then they asked them their relationship to those people. The data suggests that there's substantial heterogeneity across countries, Belgium being a very heavily hit country, Spain and things like that. A large proportion of the population was bereaved from COVID-19. Other countries is substantially lower. And what we were able to do with this is then to do kind of an individual model to look at whether individuals who experienced a COVID-19 bereavement event report worsening or current depression compared to individuals who had not experienced that event. So here's a graph showing that kind of from a predicted probabilities from a multivariate model where we control for a number of potential confounders. The ultimate results suggest that when you look at whether people report being currently depressed, those who reported being bereaved have a 42% higher chance of reporting depression, 56% higher chance of reporting that their depression has worsened since the pandemic. We did a number of other analyses which aren't highlighted here, but we found that these odds were substantially higher if you experienced a bereavement within the family, those kin types that I was describing earlier, than reported a friend or other kind of bereavement. And also that the bereavement depression links tended to be quite a bit stronger for women than they were for men. We also in this were able to look at kind of national contexts and whether living in countries with more COVID-19 mortality, absent or whether or not you experienced a bereavement event yourself was associated with greater odds of depression. And we do find, at least for women, that there are substantial increases in depression when you live in countries with more bereavement events. So for instance, those people who are, with more COVID-19 mortality. So those people who live in Belgium, for instance, women who live in Belgium tend to report substantially higher substantially higher depression than women who lived in, for instance, Slovenia. These are models that control for a number of other potential confounders. To conclude, I think that the ripple effects of COVID-19 bereavement are going to reverberate through societies, and these are going to last for quite a long time. A number of people, millions of people in the United States and elsewhere have lost those that they count on to get by, those that help make ends meet in times of trouble. And this has taken a direct emotional toll on a number of people. In terms of kind of national concerns, it's reduced productivity, education, trajectories, human capital, and family formation. And it's also been exacerbated by disrupted grief rituals and physical distancing requirements and things like that. I believe that these results highlight the need for concerted national efforts across the globe to address the downstream influence of COVID-19 bereavement, as well as bereavement overall, and recognize the challenges that are associated with this pandemic more generally. I think one last recommendation is that one limitation of US data right now is that it's not well designed to study COVID-19 bereavement, and it really doesn't allow us to track some of these long-term implications in people's lives. And I hope that before the time runs out, that we can address some of these data collection gaps. Thank you very much.
Thank you very much, Ashton. Thank you. And feel free to put your contact in the chat if anyone would like to follow up with any other questions after the event as well. Thank you. We really appreciate that. And what an interesting talk. And I'm quite astonished by the numbers, actually. And it's really important that new data comes to the front in relation to that so that we can start taking action. And I think with that, we're going to move on to Carol, who is kindly coming in to step in for Joel Mulheron, who is unable to be with us today because of personal circumstances. But Carol is also a member of the Evermore, the non-for-profit organization that is dedicated to the work that's been done about bereavement care in the United States. And I'm going to leave Carol really to introduce this a lot better than I can. And hopefully we will hear a little bit about the public health imperative from all this, which will be quite useful to follow on from the conversation. So over to you, Carol. Let me know if you need me to help you with sharing anything, if you have something to share on the screen.
Thank you. Thanks for having us today. Evermore is looking at the issue of bereavement from a public health perspective. And forgive me, I'm not the scientist that Joy Al is, but I want to frame our thinking in terms of in the United States, we talk a lot about the mental health implications of a death event, grief and bereavement. But as Evermore, we think about the three major issues that arise from unaddressed bereavement: mental health issues, medical and regular health issues, and economic well-being. And so one of the issues, Evermore has been pulling together people who have lived through a bereavement event, who have a perspective about what would have made their lives better and more livable after the death. And one of the major issues that has come up for our leadership is the issue of bereavement leave. Evermore has been working the last 7 years. Joyelle has been interviewing people in a wide variety of death situations, people who have experienced overdose, suicide, maternal health losses, homicide, and then now the pandemic has sort of solidified that there is an economic aspect to bereavement that our society is not taking into account. And so Evermore has created, and on our website, which I believe has been included in the chat, a way of thinking about bereavement leave. Our basic the idea is to provide and make sure that there is continued economic well-being of families, that bereavement leave needs to be spelled out very clearly. And in the American society right now, that's not the case. People will get a little bereavement leave if their boss is favorable, no bereavement leave if they're considered a troublesome employee. The Family Medical Leave Act only allows for bereavement leave in very limited circumstances of death of an infant before birth or before it takes its first breath. So Evermore is pushing for voluntary compliance, looking at clear written guidelines that will spell out for employees and employers what that relationship will be. And basically the idea is just don't fire someone after the death of a family member. Small employers, fewer than 50 employees, we're asking employers to voluntarily comply with 5 days of unpaid leave to allow bereaved employees time to manage arrangements following the death of a family member. Mid-size employers between 50 and 499 employees should offer 5 paid days of leave following the death of a close family member, and that the employees should have the option of 2 additional weeks of unpaid bereavement leave. And larger employees, more than 500 employees, should offer 10 days of paid leave. Large employers should offer more than 10 days of paid leave following the death of a close family member, and that the employee should have the option of 2 additional weeks of unpaid bereavement leave, which would be a total of a 20-day leave. We believe not only from a public health stance in terms of looking at a population and their stability after a death event, as well as the public good of providing and making sure that employees keep their jobs, that we're not sure if we'll be able to force any kind of public policy change around this, but our goal is to teach people who have experienced bereavement events to speak on their own behalf and hold their public officials accountable to the way that they should be treated as loyal employees. And because of the cost of replacing employees, it could be even more beneficial for employers to have a secure policy that's clear and consistent across the board for all employers in the United States. So that is one of our focuses this year. There are other issues that keep coming to the forefront about medical health and other economic well-being, such as children who lose their family, their guardians, should be able to receive Social Security benefits in the United States without going through a huge amount of paperwork. And that could secure economic future for kids, particularly kids who come from minority backgrounds or low-income families. I'm happy to answer any other questions, and I appreciate the chance to think with y'all about larger issues that affect people who are bereaved from a public health stance.
This is really, really wonderful. Thank you, Carl. I do appreciate it. And what an important piece of work to be thinking of how do we sort of take, you said I'm not the scientist, but actually you're the one who can apply it in, you know, what will happen next, because we can do science, but then we also need to do something with it. And this is really the way forward, to be thinking about policy practice a lot more and policy influence. So that's absolutely fantastic. And what an important topic. And I'm sure we'll come back to that in the Q&A segment a bit later when it comes to bereavement leave. I think that's a hot topic for many. You know, given the numbers that Ashton shared, I can't imagine, you know, how important this will be. Okay, well, I'm going to move on to Sarah now, if that's all right. And Sarah, so just a brief introduction. It's Dr. Sarah Garley-Green, who's a professor at Salem State University, and she's which is part of the University of Massachusetts, right? Yes. And she has taught a variety of courses relating to health, as well as has written a lot for publication. And she has previously worked in the UK as a patient advocate and researcher into chronic illness, which I find very fascinating myself. Since she's gone back to the US, moved back to the US, she has expanded her work to include the narrative in health, health equity and bereavement and health policy. And Sarah is also our ASDS ambassador for the USA, which is wonderful. And it's really, really wonderful to see one of our ambassadors joining us in one of these events. So thank you, Sarah, for coming here today. And we're going to hear from you about the narrative, the inquiry. Am I right? You are on mute at the moment, so.
Sorry about that. Oh my God, my students would be laughing hysterically. Yes, so I'm going to look at the narrative of health, and I'm going to share my screen with you. And I have a PowerPoint because I'm a professor and we always have PowerPoints, as we all know. My point really is that the narrative of the US is made up of the narrative of us, right? All the people in the state, in the country. And why study narratives? So I study with narratives and I study about narratives, and we use narratives. The use of narrative is ubiquitous. We all tell stories to communicate, we tell stories to empathize, and we tell stories to create meaning from events and to make sense of lived experience. And I think it's important for us to have hand in hand the narratives when we look at data. You know, Ashton's work is so overwhelming, but we have to think too about all of those pieces of data are made up of human lives. And I believe that, you know, studying individuals are important, but I believe, you know, we can use the same narrative tools to understand national events as well. So in the United States, the narrative of now, meaning the narrative of COVID-19, is really a narrative of then. The United States, Americans are not, in large, considered very reflective people. We tend to push headlong into the future and have a bit of an amnesia about our historic inequities. But the COVID experience has mirrored, laid bare the historically racist and inequitable national narrative. The American zeitgeist is that the death of COVID is a kind of failure in itself. it's the stigma of the weak, the sickly, the poor. 8 out of 10 Americans who have died are over 65. And we have to question whose life is valuable. That is a really important question when we're considering our national narrative. These quotes, just the old and the virus affects nobody, is of course our great late President Trump. And to tell you a little bit about how everyday Americans digest or understand, make meaning, at the death, the milestone of 500,000 Americans who have died from COVID, Tiger Woods, who's a golfer, drove his car off the road, and you couldn't find anything about President Biden's discussion about the 500,000 deaths. So we're really people of the moment. Who are the COVID bereaved in the States? I think that this chart shows really who are the COVID dead, and utilizing Ashton's multiplier, we can see who are the COVID bereaved. So this chart really shows the health inequities in the US healthcare system. So we have the indigenous people have died 2.4 times as much as the whites, 1.9 for Black Americans, and 2.3 times in the Latinx population. But I would point out that about half of the states collect data by race, particularly around COVID. And the indigenous number is considered a wildly undercounted number because of the way that data is collected on reservations. So the narratives of us as individual, and I'm paraphrasing another ASDS ambassador, Alfred, who said, well, to put more simply, death is universal, but grief is culturally specific. And we see the pain of existing racial bias in the healthcare system in many stories of Black Americans who have been harmed by it. The history of trauma and slavery, but the current discrimination, the bias that exists in the healthcare system really resonated with the narrative of Dr. Susan Moore, who was a Black doctor who made a video actually of her narrative about her racist treatment in the hospital during COVID. And I would say the late Dr. Susan Moore, as she died a couple of days after making it. And I show that video to all of my students in order for them to really understand the pain of health inequities. For the indigenous population or the native population, there's a history of genocide and displacement. Genocide, purposefully, the infection of indigenous populations in the 17th and 18th century to clear the way for the white people. But there's that continues today. It continues, and COVID is most painful amongst this population because, as Janida Benole, who's a DNA or traditional medicine person, expressed that people are dying and they're taking tribal knowledge with them, because in DNA medicine, the tribal medicine person teaches one person at a time to take over that tribal tradition. So traditions are dying, several generations are living together. When the older people die, the family household breaks up. Amongst Latinx population, there is a persecution of the undocumented and an intimidation and profiling of the entire Latinx population. If you look at the people who were affected by COVID, a lot of the essential workers are Latinx people, and they're afraid often to go to the hospital or seek help due to the fears over immigration status. And as a consequence, they only go to the hospital when they're so sick and they're going to die. I had a student, Gerardo Cruz, whose entire family, his sisters, his mother, father, are all essential workers. They all had COVID, and Gerardo, who's a fantastic student, had to quit college. So it affects so much of one's life. So how do we help the bereaved? How do we've got the numbers now, we have the history, we know who these people are. How do we help them? Well, due to the discrimination and past trauma, these individuals, the bereaved of COVID, may suffer complicated grief or prolonged grief. The grief can be delayed when a person has to struggle daily to survive. We all know Maslow's triangle, a hierarchy of experience. If you're struggling daily to just get through the day, then you might delay your grief, and it may lead to substance abuse and complicated grief disorders. There's a cultural and societal pressure in the United States to rush on, to just accept your grief, to swallow it and move on. And that can cause serious problems of delayed grief. And obviously there's a clear and effective public support through bereavement leave and through other sources of bereavement care. Really, we need to focus on this, as we've not focused on anything for a century. So really, what is our post-COVID narrative? Are we going to carry this baggage of inequity with us, or will we see a post-traumatic growth in the United States? I ask my students this, and generally they are very pessimistic. But I did, like 2 days ago, talk to a class, and there's a Latina young woman who is generally very quiet, but she spoke up and said, we're only going to have a positive post-COVID experience and narrative if we are mindful of our past and intentional about the future. And there's a possibility. I'm not, I feel slightly positive now. We have Biden as our president. He has a personal narrative of grief. He lost his wife, his daughter, and one of his sons. I have hopes for a more reflective government. We have a COVID director for health inequity. And we've recently had a COVID bill passed in which child poverty is considered. Social safety nets are considered with Medicaid expansion. Cash payments are given to the poor. And in fact, 68% of low income Republicans support this bill. So I am positive about what we face. And I feel it's so important that we think about narrative in terms of re-remembering, as a narrative therapist, re-remembering, re-understanding our experience. And we have a lot of possibilities that we'll be able to make a change.
Thank you, Sarah. Thank you very much. And how great it is to tie in this aspect of our understanding of grief and what really the narrative is behind everything. And it strikes a lot of questions. I think if you combine the three sort of contributions, there's so many questions that can be raised, and especially when it comes to moving forward with policy amendments, what is the narrative behind the suggestions, and what is the narrative behind the intentions of any policy that's recommended as well. So a lot of things can come up. What I want to do is open it up to the floor straight away for questions and comments from anyone at this point, and then we move from there. So over to everyone else. And if you don't have a mic, if you don't feel comfortable coming into the mic, feel free to type into the chat and I can relay your question.
That was a nervous moment as a professor.
In the meantime, can I just suggest if anyone would like to, besides this recording, have a look at the information you shared in the slides, Ashton and Sarah, is that a possibility?
Of course,
yeah. Yes. And Sarah, do you want to put also in the chat your email address once again, so that people can get in touch perhaps, or they can also get in touch with me and I can share.
Okay.
Yeah, I'll send it to you.
Perfect, thank you. So over to we're open to questions and comments from this.
While we're waiting, I just want to mention that Sarah, we are so lucky to have Sarah as a leader of one of our teams in working on public policy issues, and just very talks about the caliber of people who are joining together to make change on this issue in the United States.
Thank you, Carl. Thank you. I keep hearing wonderful things about that. And about Sarah's work, which is fantastic. Maybe I should open up with a question of my own, and then we'll move from there, if that's all right. I've got one question that could perhaps go around all three speakers, and that is about the ethnic disparities, and you've all slightly sort of touched on it. I know, Ashton, you said, that's not really that you're going to focus on, but I really want to hear a little bit more about your thoughts about those racial inequalities, and especially in light of the information that Sarah is sharing about narratives, because really what we're saying is that COVID is another reminder of things that we already knew were there. And so any further thoughts about the racial disparities, I guess, and how, what is the plan for changing that narrative moving forwards? So do you want to take it in turns, perhaps, because I can see that all three of you might have thoughts. So maybe Ashton, do you want to make a start? You are on mute, but maybe it's
Yes.
Intentional.
I have an additional slide I can share about that quickly.
Okay.
What we found were that there weren't huge disparities in the multiplier that we found. That, I mean, they do exist. It's a little bit lower for white Americans than Black Americans, reflecting slightly larger networks, particularly among older adults, because 40 or 50 years ago, Black Americans tended to have slightly more children. But these are old numbers here. You can see that the number of deaths has been substantially, but this same general logic plays out, that what we see is that a much higher, because even though the multipliers are comparable, there are substantial disparities in the kind of death rates, which when you multiply those out, translate to substantial disparities in bereavement rates. And so we still see substantial disparities, although not particularly different through the kinship networks, but slightly, but primarily through the different kind of death rate experiences. The other part of that I wanted to show is up here in the top graph. This graph does have white and Black Americans. And one thing that is worth focusing on here is that the overall multiplier is not that different, but in this age range, there's a larger multiplier for children in bereavement experiences and a slightly smaller multiplier for older adults in bereavement experiences for Black Americans than white Americans.
Really interesting, really interesting. And I wonder what else might there be, because perhaps the reporting and the recording systems are not necessarily capturing 100% of the picture. Carol, did you have any thoughts about that? Because I know you talked about policy and sort of supporting individuals who are going through this, but would that apply to also those that maybe have no recourse to particular public services?
Yeah, am I unmuted? Sorry. We do see a great deal of inequity in, and evermore, I put in the link, our facts and figures document, that we have a sheet called the Facts and Figures for Black Americans. And we see a great deal of inequity for people of color and people from low income backgrounds in terms of the kinds of resources they're receiving to interrupt or support their bereavement. Black children are exposed to death at an earlier age in life and lose parents at a higher frequency. By age 20, Black children are twice as likely to lose a mother and 50% more likely to lose a father when compared to white children. And Black parents are exposed to child death at greater rates than white parents. The inequities seem to hold across all race lines. And there's very little factual data and research on Latinx and Native populations in the United States. We were able to put together the facts and figures for Black Americans. And the way that Evermore is looking at changing this is by involving people who are generally not a part of the discussion in changing the shape of bereavement care systems. We look to a time when Americans can hold their public officials accountable. We're also looking at ways that we can support greater research with more information about populations that have not generally been included. And I have to say, from what Sarah mentioned in her talk, I'm one of those people who were the cast off COVID folks. It's like COVID doesn't affect anybody important. People with respiratory difficulties and disabilities were not considered to be important players in the COVID death situation. And so I know what it's like to not be included in that conversation. And so that's why the work that we're doing at Evermore, in part to make sure that the research reflects the real nature of our communities, and then in part to involve people who have not in general been a part of the conversation. And so that's the work that I'm doing in terms of outreach. But we do see so much inequity, and we have to be able to change the way people think about who are Americans in order to have more success in creating a system that affects everybody and supports everybody equally.
Thank you very much, Carol. Thank you. Sarah, did you have any thoughts on that as well?
I do, and building on what Carol said, yeah, I do work with Evermore, and I feel that the what we have in our culture, our American narrative, is that we don't value every life. We don't value every life the same. And so that has a lot of, I mean, I could give you an hour's lecture on the Puritan basis, the basis of slavery and how that's continued, our laws on certain drugs, the imprisonment of Black Americans. I could talk for long time about that, but I won't, because really we're looking at the inequities in relationship to health causing death, and then of course those who die are bereaved. Health inequities in the United States are enormous. It's a field that is really starting to get attention. I decided to teach a course on health inequity, and really the options for textbooks was very small. It's something that we really must concentrate. And again, I'm not pessimistic about that. My students, young adults, are a lot more pessimistic than I am, but I do feel that we have the opportunity. And the reason why we have the opportunity is we are focusing on allowing a greater narrative, a greater voice to people of color. And that's one of the things that we're trying to do with Evermore, is allow a greater option, a greater ability, a greater equity in voice. And that's what I did when I worked with Black women who have type 2 diabetes. Everyone said, oh, you can't do narrative work. You know, these people are not literary, have a great level of literacy, so you can't do narrative with them, which was just nonsense. There are ways to work with any population, and these voices need to be heard.
Thank you, Sarah. Thank you. I'm mindful of time, and I know there are a few questions in the chat, so I'm gonna relay a couple of those, and then you can we can see how we can manage them. So Tamara wants to ask, and I think Sarah, you might want to take this one. It's just telling us, given that there have been so many disruptions to services for those who we have lost in the past year, are there any recommendations on how we as a society can grieve and remember those that we have lost? And what can we learn from narratives about this?
Yeah, well, absolutely. I think that, you know, the numbers are so overwhelming that it's very hard to focus on the individual people. There are lots of possibilities for working with people. I could teach anybody here how to work with somebody to express their narrative. But I think also you know, the saying goodbye, the bereavement has been disrupted. And we need to, as a nation, focus on those who have perished in this time and those who are left bereaved.
Can I also ask that you take the next question? There's a question from Adriana, and welcome, Adriana. Who I'm going to put you on the spot. Adriana is also our ASDS ambassador for Romania, so it's really wonderful to see you here. Adriana is asking whether there is a narrative of COVID-19 vaccination in the US and how that relates to the COVID-19 narrative on the whole.
Yeah, so absolutely, Adriana, this is something that I'm very interested in because it's very possible that the success that we've had in science will overwhelm the narrative. The fact that we've been able to go and, you know, develop all of these vaccines, yeah, that's a happy story. But who's getting the vaccines? Is the vaccines, is it an equitable distribution? And you know, this is maybe the last part of the story, but it shouldn't overwhelm, it shouldn't dominate the story that came before.
Yes, Carol, did you want to come in? Your hand was up.
Yes, I just wanted, from my own personal experience as a person with a respiratory disability, I have muscular dystrophy. My community here in Oregon prioritized getting the vaccine to people by way of a congregate site at the convention center, which is 8 miles from where I live. I have no transportation that's wheelchair accessible. And I'm not able to go on the public bus. And because of the style of wheelchair I use, which is a 3-wheel, I'm not allowed to use medical transportation. And so there was no way for me to get to a site. And to me, it's very interesting. There are 20 other people who live independently in the community who also use ventilators. And there was no provision for a way for us who do not have transportation to get the vaccine. And so, you know, I've had to, this is not an issue for Evermore, but the point being that there are people left out of the conversation. When the decision was made about how we would roll out the vaccine, the people like myself were not a part of the conversation. And I could have told you that there would be a problem if you think that everyone has access to a vehicle. And during the pandemic, I cannot use the public transportation. So it feels like public systems need to be more responsive to the reality that not everyone looks exactly like everyone else and doesn't have access to kind of taking for granted that you can get 8 miles across the city in 29-degree rainy weather is a ridiculous idea. So I think, you know, my experience as a person with a disability, and then also you have people who do not have resources that would have availed them of the vaccine earlier. Things like the number of people who have access to electronic scheduling like iPods and smartphones and computers. So, you know, I can at least just speak from my own personal experience, and there's a piece missing, and I'm not the only reflection of that.
I think it also might be important to make the point for an international audience that every state decides what the eligibility is. So in Florida, they didn't prioritize the healthcare workers because the older people vote more. They prioritize those people. So every state is different. Every state has to have a rollout. Every state decides eligibility. That is something that I think a lot of people from other countries will find pretty shocking.
Thank you very much, both of you. And Ashton, I wanted to quickly sort of ask if you thought that, sorry, something popped up on my screen. If you also thought that having the vaccine as a narrative sort of responds a little bit to the immediate sort of crisis of depression levels, if you like, from what is currently happening.
I'm not sure is the right answer. I do think that it certainly is better. I mean, I can speak for myself, just looking at the numbers today and updating them compared to the January numbers. I mean, it feels like we are in the beginning of the end of the crisis. And so I believe that probably helps. But I don't know how general that sentiment is, but that's certainly my appraisal. And I think that the burden of this on people's mental health, the vaccine is probably relieving that to some extent. There is like a light at the end of the tunnel, at least, where the crisis might end. But certainly if you've lost a loved one, I'm not sure that that getting vaccinated is going to, make that whole, it's, so it's hard to know.
Thank you. I appreciate it very much. And I think because of time, I'm mindful of people's availability. People might need to move along because we're all in different time zones. I think we're going to draw this to a close, if that's all right. So unless there are any other burning questions, something or a comment that somebody would like to share, I'm only sharing a slide on the screen that gives a little bit of information about ASDS. Feel free to contact me if you have any questions about ASDS and the seminars. We do hold a seminar, a webinar each month. And all of that is advertised on the website, I should hope. Otherwise, I shouldn't have said it. But I think this will be all from us. Can I ask that Ashton, Carol, and Sarah, you share a 20-second thought, like final thought, as a takeaway message for all of us that are here today?
This is Carol. I think what I'd like to say is that we who care about this area are the solution waiting to happen. And if there are any people who would like to know more about what we're doing or have us help with what you're doing, Evermore is ready to be helpful. And I put my information in the chat.
I'll go. For me, I think it's helpful to consider this COVID-19 crisis and the mortality associated with it and the bereavement associated with it in a broader context. We have 500,000 people or more who've died from COVID-19, and that has led to a substantial bereavement shock in the United States. But on average, about 3 million people a year die in the United States, and there's a substantial bereavement shock from that as well. So while we're up to 3.5 million versus 3 million, there's still a lot of issues in regular years as well, where bereavement is a massive public health and public policy challenge. And I think that there needs to be substantial efforts to address it. I think the colleagues on this panel have suggested a number of possible and important directions that are being pursued.
Thank you, Ashton and Sarah.
Yeah, Ashton, thank you for that. I think that there is a danger that those who have died not from COVID in this time are disenfranchised. And we need to be thinking about the bereaved and those who in the United States are people of color. They have a persistent and existing trauma in addition to the events that happened to them with COVID. The work that I've done with African American women, those who have experienced significant trauma do have a greater difficulty coping, finding mechanisms to integrate illness and bereavement into their lives. So we have to be mindful of the individual histories of the country, but also the individual histories and the effects on the identity of the people that make up the country.
Thank you. I appreciate all three of you and your words today. I think it's been really useful, and there have been really great messages in the chat. I don't know if you've been following it, and people have really enjoyed these talks. So thank you all three. Maybe what we can do in this situation we're in, just give you a nice little applause. applause with the features of Zoom. So thank you very much, and thank you to everyone for attending. Thank you for sharing your thoughts in the chat. As I said, I'll be happy to share the slides. Sarah and Ashton can send those to me, and I'll share them all at once. That will make it easier. And see you all in a future event.
Thank you.
Thank you very much, everyone. Thank you. Have a lovely evening or morning.
Thank you.